And I can't tell you what city, but it was in New Jersey.
Just know that you'll have access to this presentation after it's over. So if you're interested in going back and listening to it again at a certain point. So I'll go ahead and share my screen. Actually, why don't you open with prayer, and then I'll go ahead and do that, Professor.
Sure. In the name of the Father, and the Son, and the Holy Spirit, amen. Lord God, we just ask you to send your Spirit upon us today so that our hearts may be open, our minds may be open, and that you give us eyes to see and ears to hear. And we ask that you speak to our hearts, bring us to a great conversation, and allow us to find ways within our hearts that we could share this information with others. St. Thomas Aquinas, bless this time and pray for us. In Jesus' name we pray.
Amen.
I'm going to go ahead and mute everybody and then share my screen.
Ready to go in the other room?
Higher last hour if we and affect our families and our friends. And a very warm welcome to everyone to tonight's webinar from Catholic Distance University, cdu.edu. Our topic tonight, as all of you are aware, decisions of life and death. All of us are aware of the crises in health, the end of life, crises that affect all of us and affect our families and our friends. When faced with these life and death situations, we often ask very important and even heartbreaking questions. And we ask those questions in times of stress, in times of exhaustion. And among those important questions are we dealing with these death and life issues, the end of our lives, the end of our relatives' lives, in ways that are consistent with the teachings of the Church? Are we actually benefiting our loved ones? And are we making sound moral decisions, sound prudential judgments in care and those end-of-life decisions? All of that is going to be a topic for us tonight, coming on the heels, as all of us know, with the recent passing of Alfie Evans in England, coming on the heels of that, of the recent case of Charlie Gard. So end-of-life issues, euthanasia, how do we care for the dying? These are pressing topics for today. And to deal with all of that, I have the distinct pleasure of being joined tonight by Stephen Boza. Professor Boza teaches for us at Catholic Distance University the field of moral theology, but he's also an expert not just in moral theology, but in bioethics and family life. He is the head of the Office for Life and Family for the Archdiocese of Philadelphia and is one of my favorite faculty members here at CDU. Stephen, welcome.
Thank you for having me, Matt.
Well, we have a lot to cover tonight, but I also want to invite all of you here in the audience to submit your questions. If you go to the right of your screen, you'll see that you can post questions to us tonight. And there is, as I was saying, quite a bit to discuss. I know that you have questions already lined up because we've been receiving them from you in anticipation of tonight's webinar. But let's get the ball rolling with this conversation with Stephen Boza. Stephen, let's start with the most basic of questions. If you were advising a family facing difficult medical situations and likely end-of-life issues, what is the first piece of advice that you give to anyone in what is that difficult situation?
My first response to them would be to probe your physician and know how to ask the right questions. Because in my experience here working for the Archdiocese and also in the practice of bioethics, what I find is that many people don't know the right questions to ask. And so therefore, if they're not going to ask the correct questions, they're not going to get the answers that they need. And I'm not one for faulting the physicians for hiding things, because I don't think they do that, at least the physicians that I've had the privilege to work with. But yet they're not mind readers.
Mhm.
And so we have to be able to ask the right questions. For instance, if a person is, if a physician's asking a person, you know, I think it's time that you guys make some decisions on the care of mom or dad or whomever. Well,
Mhm.
the very first question that needs to be raised with the physician is mom in a state of medical futility? Now I'll explain what that is, because most people don't know that that even exists. That
Mhm.
even exists. And so, but that's really going to be helping us to make a determination. So what is medical futility? Futility tells us that there is nothing more that any physician can do to stop the inevitable, which means death. And so there's a process and a way of kind of exploring that, but the physician needs to be asked directly, is mom or dad or my husband, wife in a state of medical futility?
Mhm.
And we can't accept the response that we can make a case for it, because
Right.
you can make a case for anything. And we don't want to do that. We want to know the facts. We want to know the clinical facts, yes or no. And then if there's something else that could be done, then we have other assessments that we have to make.
Well, you've already started using the terminology that is consistent with end-of-life care, with those who are in the end stages of life, but also those who are facing medical crises that could be genuinely life-threatening. You just used the word futility, for example. That has, I know, a very specific meaning in the case of medical care, of bioethics. For those who are uninitiated, lay people who find themselves in these dire medical situations, what's a piece of advice you can give them to, we don't have the time, for example, to study up on terms for preserving ideas of medical act, of DNR, DNI, all of that terminology that you can be bombarded with by a physician. So what do you advise somebody who has no experience in this, but who can be easily bedazzled and sometimes even bulldozed by a medical practitioner?
Yeah, I think we have to think forward. And one of the ways that we think forwardly today is through, say, tools like living wills or advanced directives. And we could talk a lot about that if you want.
Yeah.
But it's, you have to come into an understanding of these things before they fall in your lap. And so I would recommend people who have healthy family members, who are healthy,
Mhm.
to check out a few resources that many publishers have these days. I can tell you, I wrote a little pamphlet. If it costs $1.50, it costs too much, with our Sunday Visitor.
Mhm.
A number of years ago, that gives people the basics. All they need is the basics to help start the conversation. You know, that's why our work with this in CDU is so very important for deacons. You have a bioethics certification course for our deacons. But it's so important to get the clergy to understand these things, because I tell you, we can't fault them for not knowing. I mean, a lot of times the people in seminaries today are getting good bioethics, and that you know that those individuals, those men are coming to understand a little bit more of the nuances that could help a parishioner in these times of need. But you know, you have older priests now who've been in the ministry for 10, 15, 20 years that, you know, that unfortunately don't have all the updated information that they need.
Yeah.
And so you can't fault them for that. So my recommendation has always been, look, speak to your parish priest or your deacon. And if they don't know, then call the National Catholic Bioethics Center. I've had a 20-year relationship with these men and women there, and are very, very open to doing consults. You need to speak to somebody that knows more than you do, so that they could help navigate these waters that we find ourselves in.
Yeah, exactly. And these seem at times now pretty deep waters. I want to read something from the Catholic World Report written by Christopher Altieri just a few days ago with regard to the case and death of Alfie Evans. And he notes that it raises issues that must be addressed. He writes, and I'm quoting, "Tragically misguided medical ethicists have made quality of life a controlling criterion for determining whether to give care, and in some places like the Netherlands, even applied the standards in a way that leads medical professionals to participate in the deliberate termination of life. In jurisdictions like Iceland and Denmark, somewhere between 95 and 98% of the pregnancies returning a positive result from a Down syndrome screen and in termination." So we're looking at the wholesale extermination of children with Down syndrome. In your time of study and your work in the Archdiocese and elsewhere, I know, how have you seen, or can you chart sort of the deterioration of medical ethics, and how did we get here?
Well, the issue of quality of life is extremely subjective. And I've often told people who come into my office or my students, stay away from that term. Because my quality of life may be different than your quality of life, or maybe different than somebody else's quality of life. I'll give you an example. One of my cousins is close to 60 now. He has Down syndrome. Can't do what you and I do, but he's as happy as they come. You know, he lives with his sister and her family, and, you know, he has a job, and, you know, that doesn't pay a whole lot, but you know what? He's got a great quality of life.
Right.
Happy. And so and John Paul had spoke about this too, and cautioned people about using that term as well. I think it's better to talk about human flourishing. Is this person going to flourish? Is this person going to be able to live what is normal for that person? So in terms of the term quality of life, I don't use it, and I don't recommend people using it, because it's not something that's very dangerous. The devolution, I think, of ethical standards has, you know, and I've thought this out, and I've worked it through, and I've talked to other people about it. Look, when we've decided that we could be the arbiters of when life begins, it's a short move to decide when life ends. That culture of death, that's where it starts, with the whole contraceptive mentality, and the idea that if you're not going to be perfect, then you're not going to be able to live the life that you want. So there's social conditions involved with this. There are theological conditions involved with this. It's a general movement towards, I know better than anybody else. That moves into the medical profession oftentimes. We've gotten into this place because it's a, you know, if you look at the medical schools, if you look at what people are being taught, you know, death is a part of life, which is a true statement, but it's also not something that we ought to be causing.
Yeah, understood. So we're already getting quite a few questions from the audience, so I want to jump to those. This is actually from a physician he's asking, instead of the family studying ahead of time, as a physician, he would recommend that the family ask the physician to explain the circumstances at what is described as a blue-collar level. Do you find that works?
Yeah, I do. And I think that it's the onus is on the medical professional to bring things down so a person could understand it, yes. But we ought to be educating ourselves as well, and doing what we can to learn some of these things. It's not like this isn't going to be necessary. It's not like this is a luxury. We need to learn it for ourselves, you know. And also, you know, physicians today with healthcare being the way it is, they don't have time to sit with you. When you're going into a doctor's office, or if you're in a hospital, the doctor will do his rounds. They have X amount of minutes to spend with you before they move somewhere else. Right. So is it just to ask the physician in this climate to spend a half hour or the 40 minutes to explain some of the things that you need to explain. I don't know if that's possible. I mean, he's the physician, so he would know.
Right.
But we have to do what we can to educate ourselves.
Yeah, and oftentimes you end up actually spending more time talking either with the nurse practitioner or the nurses on the ward. And
Absolutely.
yeah. Well, that was a question from Dr. Paul Carpentier, so thank you very much. I want to come back to the technical questions, but I want to sort of establish something very early on here, and that is, I want to read a quote from Pope Pius XII, in which he said that life, health, all temporal activities are in fact subordinated to spiritual ends. And in light of that, could you sort of lay out for us some groundwork for an understanding of redemptive suffering? I ask that because one of the things that we hear so much today is this reluctance to impose any kind of suffering, that has to be alleviated, even at the cost of killing a patient or a loved one in the name of avoiding or alleviating suffering. And we'll deal with pain management in due course, but talk about redemptive suffering for us.
Well, in terms of healthcare and in terms of a person's health, we could do the best we can to alleviate pain, and we ought to. It's inhumane to have someone reeking with pain and not being able to do something. At the same time, we're not going to be able to get rid of all of it. We can get rid of what we can, but we're not going to be able to get rid of all of it. And then, as Christians, we're very, very fortunate to have the theology and the knowledge and the revelation that we can join our sufferings to the sufferings of Christ for whatever the reason is. You know, it's redemptive. My suffering is redemptive to me because it calls me to look inward. What am I doing wrong? What is it that I need to deal with? What is it that I need to seek repentance of? All those various and sundry things. But it's also redemptive for the person who is watching me suffer, because that object of suffering, as John Paul calls it, St. John Paul calls it, causes me to come out of myself to serve you in your suffering. And frankly speaking, that's my ticket to heaven or my ticket to hell.
Yeah.
And so, you know, suffering has meaning for both the sufferer and the one who witnesses the suffering. And it's up to us to take that and bring ourselves to a place of repentance, forgiveness, whatever it is that we need. And when we decide that we don't want somebody to suffer, if I decide I don't want to suffer, I rob myself, or you rob your loved one, from having that process of seeing the things that need to be corrected and to enter into eternal life. Because we would block that out. We block that out.
Yeah, on a personal note, I would encourage anyone, especially under these circumstances, to read John Paul II's magnificent document, Salvifici Doloris,
Yes.
which looks exactly at what you're describing. So with that in mind, let's jump to another question. And this is, would it be okay to ask for resuscitation of any kind, or do we just let the person die naturally?
Well, that's a very complex question, because it takes us to a number of other issues. So let's look at resuscitation first off. We should do what we can do. If we're looking at a need for somebody to be jump-started, whether it be through the paddles or what have you, all these things can be done and maybe should be done. But we have to look at the assessment of benefits and burdens. What are the burdens of doing this? And so if you have a person who is in frail health to begin with, maybe an elderly person whose bones aren't all that great, and you know, is that resuscitation going to do more harm than good? Well, yes, in that instance, yes.
Mhm.
And so we should, at that point, legitimately put on do not resuscitate order on this person.
Okay.
Because that whole process could be overly excessively burdensome for that patient. But then again, there are other issues and other circumstances where that wouldn't be the case.
Mm-hmm.
And so we're talking about proportionate or disproportionate care right now.
Okay.
And we'll explain that as we go along.
I was going to say that those are two of those technical terms that we all have to grapple with. So when we're talking about proportionate and disproportionate, let's put that as Dr. Paul suggested. Let's put that in blue collar terms.
Okay, in blue collar terms, proportionate care is something that will offer reasonable hope of benefit, and I'm emphasizing that term benefit. Because that sentence has been reworked by certain ethicists that is not correct. It's reasonable hope of benefit. And that would be proportionate to this particular patient's care. But a disproportionate care would be something that doesn't offer reasonable hope of benefit, or something that the burdens are more are going to be more pronounced than the benefits.
Mm-hmm.
That's what we have to look at. What is the assessments of benefits and burdens? If the burdens are becoming too great for a person, then we don't need to go there.
Mm-hmm.
You know, so you know, if there are more benefits than burdens on this, well, then we ought to consider going through it. And again, we can't make blanket statements in a forum like this because we don't know the facts of the case.
Right.
But
it's helpful to have a certain set of guiding principles, which is what the church offers consistently. I think that would be a fair statement.
Yeah. Oh, absolutely. Yeah, absolutely.
Now, in a way, we're also talking about obligatory versus optional medical means or medical care. And how do we tell the difference?
Well, that which is ordinary care also offers reasonable hope of benefit, but it's also something that is done almost routinely. It's something that is not experimental, not burdensome. Extraordinary and ordinary care is important, and we have to be doing that. We're obliged to do that. We're not obliged for extraordinary care.
Mm-hmm.
And extraordinary care is something that is experimental, that is, not offering reasonable hope of benefit. That's basically disproportionate to a person's care.
Mm-hmm.
It can be experimental. I think I may have said that already.
Mm-hmm.
I'll give you an example of how in medicine today things are moving and shifting. Back in the 70s, cardiac bypass surgery was only done in Houston. And it was not something that insurance companies were, apt to, to pay for. And it would cause, and they really didn't have a good track record. Today, it's like taking your tonsils out.
Mm-hmm.
You get, not as it's more severe, obviously, but it's done all the time. It's always covered. It's going to work most of the time. And so that moved from extraordinary care to ordinary care.
Mm-hmm.
In the 70s, we did not have to do that. In this new millennium, then that's ordinary care, and we're obliged to go through that if other circumstances prove that we can tolerate that.
Right.
And again, we have to know the facts of the case.
Yeah, the specifics of the case. Relative to that is you used the term a little while ago, do not resuscitate. For anyone who spends much time around emergency rooms or with the patients who are in end stages of disease, or very frail. One of the terms that you hear all the time is DNR, DNI, AND. What are some of those terms, and what are some of the things that as Catholics we need to look out for when doctors are describing them or suggesting them?
Well, first off, we have to look at the healthcare facility, because the facility itself takes it upon themselves oftentimes to change the definition of what a DNR is. Do not resuscitate has everything to do with cardiopulmonary resuscitation.
So by way of example, that would be things like the paddles, the famous.
That would be the paddles, that would be,
Right.
You know, whatever else that, you know, the mouth to mouth, or whatever else that person needs to do to come to start breathing again.
Mm-hmm.
Some facilities I know are construing DNRs to mean do not give certain types of medications, don't give they have levels, DNR 1, DNR 2, DNR 3. That's baloney. A DNR specifically is cardiopulmonary resuscitation, period, bottom line.
Okay.
We can't let that morph into anything else.
Mm-hmm.
Okay. The problems that I see with DNRs is when they're put on a living will.
Mm-hmm.
We should never do that. Simply because, how do I know that if I write my living will today, 5 years ago or 3 years ago, or from now rather, when that has to be executed, am I going to be in the medical condition to justify this DNR? And if they do it, and I could live a very good life for another 20 years or 30 years, then I'm dying prematurely.
Mm-hmm.
We can't look in that crystal ball.
Right.
We put in a DNR only when we are ready to say that for ourselves. You know, DNI, do not intubate, has everything to do with being fed. You know,
Right.
Now again, we don't want to put that in a living will, because how do I know 3 years from now if I'm in some type of situation where I may need that to get by a hump until after I'm able to eat on my own again. So I don't want to put that down unless I really need to do that.
Yeah.
You know,
Well, it's interesting because we have a question from Teresa, who's asking that very question. When is it okay not to use a feeding tube?
well, John Paul has an allocution that he put out a number of years ago, probably in the 90s, that specifically talked about feeding to artificial nutrition hydration would be ordinary care, not extraordinary care, and therefore it's always obligatory. Now there are certain times when we can take them out legitimately. One condition would be if the dying process has already begun. That nutrition and hydration is not going to be absorbed into the body. And so we don't need to keep that in there to prolong the dying process. If we are at a place where it's too difficult to administer, and that could be a lot of things. Maybe your body can't tolerate the ports or whatever it is that are used for the intubation. If it's infectious or any of those things, we don't need to go there. If death is imminent, and when I say imminent, I'm not talking about next month or 2 months from now. I'm talking about within hours. We don't need to put it in there. So they're very short, small instances where we don't do that. So it's safe for us to say that 99.5% of the time we should always keep it in there.
Yeah.
Except for some of those other conditions. When it becomes too burdensome, for the patient. We can't do it.
Well, a couple minutes ago, you used the phrase that you have to be aware of your facility. And all of us over the last weeks became very much aware, I believe it was the Alder Hey Hospital in England, that became embroiled in the case of young Alfie Evans. And of course, Pope Francis very famously offered a helicopter to airlift Alfie to Italy. The Italian government went so far as to grant Alfie Italian citizenship and may actually pursue, apparently, from what I understand, as of today, some legal proceedings against the hospital or those who might have been involved. Now, we'll see if anything comes of that, but that really brings us to the question regarding Alfie Evans. Now, we don't have all of the details, I understand that, but from what you've seen from the Catholic perspective of moral theology and of ethical considerations for end-of-life issues and proper care, just what is your assessment of that whole case, and how do you think it should have played out versus the way it did?
Well, again, we don't know the facts and details of the case, and that will tell us everything. But that's not the point. That's not the tragedy. That's not the immorality. The immorality, as I see it, is a violation of the parents' rights. We see in Catholic theology, in moral theology, especially Catholic social teaching, we talk about this principle of subsidiarity. And subsidiarity directs us and leads us by saying decisions should be made by the lowest level and not the highest level, which means that the free and competent individual has the right to make medical decisions for themselves, and that's what we call autonomy. We know
well, let's stop there just for a second for clarity's sake.
Okay.
The argument that we should bring it to its lowest level seems today to run very counter to the idea of, well, the physicians in this case or the experts should know best and should have the right to impose their superior knowledge on a situation, in this case, on Alfie Evans's parents, because certainly can't you make the argument, they would say, that the physicians, that the experts know best. So how do we argue the subsidiarity?
Well, first off, we've moved away from paternalism many, many years ago. And so that's not an argument that holds any water.
Yeah.
You know, now, for us, the parents need to make that decision, not the government, not the hospital. We don't know the financial means of Alfie Evans' parents. Would it have been possible for them to fly or airlift their child to Italy? It's not a very long trip. Could they have done that? The other question that needs to be asked is, would that child have made that trip? Was that child medically able to make that trip without dying?
Mm-hmm.
We don't know the answer to that. But let's assume that the answer is yes, the child could have made that trip. Well, then the hospital is in grave error for not allowing the parents to do this.
Mm-hmm.
Because they say something is correct does not mean it is in fact correct. Now, it could possibly be that the physicians were correct, that he was in a case of futility. There was nothing, but let the parents make that decision.
Mm-hmm.
You don't make that decision. And if that's superior knowledge, fine. But the point of the matter is, it's the parents who have the right to make the child's decision for him and take them over to Italy. Now, if the child dies in the process going over there, I'm not going to incur, say that these persons have done something wrong or evil. I'm not going to do that.
Right. Given the diagnosis and the prognosis,
yeah,
in this case.
Yeah, I mean, so I guess the questions that need to be asked is, what I mean, were the physicians correct in saying nothing's going to help this child? And if that's the
Right.
case, then just let the child die. That's what we call medical futility. That's where we are. Parents couldn't accept that. Okay, allow the parents to do what they need to do, and if it helps
Right.
the child, fine. But the physicians in that hospital should not have ever stood in the way.
Well, and a question that sort of flows from that is, for the good of a family, for the good of a patient, under those circumstances in which the patient has no hope of long-term survival, and we're at the point where no treatments will prove effective, why not allow a patient to be moved from the hospital to their home, where they can die surrounded by family, but also can die comfortably and in surroundings that might be more familiar to them?
What you're talking about is the classic definition of euthanasia. We've bastardized that phrase, or that word in modern times. That's not what it was meant to be understood as. Euthanasia classically is two Greek words, eu, which means good, and thanos, which means death. What is death? And to the ancients and to the people, even, you know, for quite a while into modern times, saw euthanasia as the good death being at home, surrounded by your loved ones in a comfortable setting, as free of pain as possible, and then slipping off into eternity.
So go ahead.
That's not the way we see that word today. And so, so yes, he could have died at home, you know, which bolsters our case. If that's the parents' wishes, well, then let the child die at home.
Right. Now, at home, you can receive hospice care. You can receive, obviously, medicine and hydration and nutrition because it's possible. So the question that sort of flows from that then is artificial nutrition and hydration considered a sort of a natural means of preserving life, or is it considered a medical act? And why is there a qualitative and significant difference?
Well, I think the biggest difference is, see, we're in unfortunate times where even some Catholic bioethicists, and I put that in quotes, would use a number of things to justify not putting in nutrition and hydration. Now, I used to use a textbook written by Kevin O'Rourke and Benedict Ashley on bioethics. And Kevin O'Rourke is a great bioethicist, but he's bought into the idea that we just talked about Pius XII's document where he talks about, you know, medical means and spiritual ends and spiritual means. They've used that to justify removing of nutrition and hydration, which is false. They've used other things. When I emphasize greatly that we have a procedure must offer reasonable hope of benefit, they've changed that to reasonable hope of recovery. And by those semantic changes and word changes and wordsmithing, they're able to switch and to say that nutrition and hydration is not ordinary means of preserving life, but they are means. They're medical ends, and because they're medical ends, this is extraordinary care, and therefore extraordinary care is not obligatory. And so,
how does one go about defining recovery under that context?
Well, you just have to look at the Terry Shiloh case. Terry was not dying of anything. She would never recover from the PVS state that she was in, but she wasn't dying of anything. And so to remove the nutrition and hydration was the act that killed her through starvation.
Right.
That was the tragedy.
Which medically is one of the worst, to be deprived of nutrition and hydration in particular is a very, very difficult, painful way to die, isn't it?
Right. That's
Yeah.
right. He lasted for 2 weeks.
Right.
You know, she's lasted for 2 weeks because they manipulated the language to make it look like something that she should not have had. Church was totally against the removal of food and water. Ethicists were totally against removing of that. But again, it's the courts overstepping the role of her family, which would have taken care of her for the rest of her life.
Right.
Courts and the government cannot get involved with these issues.
Yeah. Well, in raising the Shivo case, you have prompted a related question then to that, which is the difference between a persistent vegetative state and what we're obligated or asked to do in a situation like that. First, if you could, for lay people, define what we mean by a persistent or persistent vegetative state, and then go from there.
Okay, to do that, we have to look at brain death. And in the two main sections of the brain, and there are other sections I know, but in Terry's case, the brain stem was working. She defecated, she menstruated, she was able to absorb food, digest, breathe, all those various and sundry things she was able to do because her brainstem was still alive and still working. She had a problem with the upper brain, which ceased to make her act, think, you know, and be able to do things that you and I can do. You know, the cognitive.
Right.
So she was not dead. So from a brain death criteria, she was not dead. And so, so in cases of PVS, it's the upper brain that is not working properly or functioning.
Mm-hmm.
Now, there's some science out there, and I don't really want to characterize it because I don't fully know it, and I haven't really read that much about it. But there are places. There's one place right here in Pennsylvania, in Peoria, that's doing neurological rehabilitation.
Mm-hmm.
It's at the Paoli Hospital,
Right.
and they're having wonderful success. Now, is that going to help matters? I don't know the answer to that, but people are moving in that direction. You know?
So, yeah, which raises, to go back to your observation earlier, what is deemed now as extraordinary could in not necessarily long time prove to be fairly ordinary treatment.
Correct, but that would not address the issue at hand, and that the issue at hand was nutrition and hydration. And St. John Paul has shut that door. Now, whether ethicists want to accept that idea or not is another story, but he shut that door in his allocation. And that nutrition and hydration is always ordinary care.
Mm-hmm.
Always care and not treatment. Because if you start looking at it as treatment, you can make other cases, and we don't want to go there.
Right. Well, related to the idea of ordinary versus extraordinary, we have a question from the audience that at what point, this is from Matthew, who wants to know, at what point, if any, can a lack of finances make something that would be ordinary care into extraordinary care?
Yes, that's where we assess benefits and burdens.
Mm-hmm.
And so we're fortunate in the US and much of the first world where finances aren't the issue. But sometimes they can be. Like, for instance, if you're in, you know, end-stage renal disease, where you need a kidney transplant of some sort, and you don't have the money, and you know, to be able to help pay for some of that stuff, if your insurance isn't going to cover it, or if you're not, or you don't have insurance, well, then that's a burden. And families and individuals are not required to bankrupt themselves for the sake of medical care. So yes, excessive financial stress it can be a burden, and in that burden, we find a justification for withholding the treatment.
Mm-hmm. Which is very difficult for families, isn't it?
Yes, and you know, the third world and others that aren't as fortunate of us have to deal with that all the time.
Mm-hmm.
And
Well, go ahead.
no, that was it.
Yeah. So we've had a couple of questions from the audience and also from the web. So I'll sort of pull them all together because they're all asking essentially the same point. And this is one of the questions that I was looking forward to anticipating asking you tonight. And that is, I've been through a number of hospice situations myself with relatives and family. And you could see that the work of the hospice workers, which is, in my personal experience, has been over the years fantastic. But the question that was asked here is, somebody wrote in that he sat with a close friend as he was dying of cancer, and the patient was not responding and appeared to be unconscious, but showed no sign of discomfort. The hospice nurse was giving him morphine every few hours, and I think you know where I'm headed here. Then at a certain point, with permission from next of kin, with the approval from the doctor, she increased the morphine to every hour. I'm not sure what the dosage was, but I was wondering if the nurse was hastening death rather than managing his discomfort. Are there prescription limits and guidelines regarding this? And it's similar to other questions that we've had, is it permissible, especially with something as powerful as morphine, given its impact on respiration and other things, I believe, to administer those? And if so, what are the guidelines? And if not, why?
Well, the main guideline for the administration of pain medication is the principle of double effect. And so let's talk about what that is. Double effect is defined as one act which is good in itself, and it has two effects: the intended good effect and the unintended and evil bad effect. The bad effect cannot be intended. There can be no other ways of doing this, and it has to be a grave reason for using it. So let's look at double effect as it goes with the administration of morphine in this particular instance. The good effect is going to be the relief of pain, but it's going to depress your respiration. Mm-hmm. And in doing that, this person is going to die sooner rather than later. It will have that effect of hastening death, if you will.
Yeah.
What we have to be careful with is that this is not a lethal dose is not given, mm-hmm. because that's not the principle of double effect at all. Mm-hmm. You can't be given lethal doses on this. Now, what would be a lethal dose for this particular individual that asked the question? Don't know the answer to that, because it has everything to do with the person's weight, his body structure, has everything to do with the comorbidities, has everything to do with his whole being as an individual. So somebody may be able to tolerate X amount of morphine and do well with it. Mm-hmm. Other people may not be able to tolerate that. Now, was the nurse within her rights to titrate it up? I don't know the answer to that. Maybe yes, maybe no. Mm-hmm. If in her estimation, or in the physician's estimation, that what she titrated it up to was not lethal, mm-hmm. well, then she could have done that. Yeah. But if that was known to be lethal, then she killed him. Mm-hmm.
Right. So we're beginning to appreciate more fully, I think, the complexity of situations like this, as well as the importance of understanding the basic principles that the church offers, and then try to apply them in a way that is most fitting for you. I think would be a good way to put it, would it?
Yeah, and I tell you, over the years, I've taught nursing students, and a lot of times they come in racked with guilt on this one very issue. Because they said, you know, I gave them the morphine and then a couple hours later, the guy died. And we had to go through the whole thing. I had to go through the whole thing with them. You know, what was considered a lethal dose? What was not? Did you give them a lethal dose? Did you not?
Yeah.
Well, we knew that stuff. So people just don't understand.
Right.
And they become very, very guilty. You know, I had a situation once in my own family with one of my uncles had COPD, and he was dying. And I was there with my cousin, and the nurse wanted to give him some morphine, and you know, I couldn't really do much about it because I wasn't his son, I was his nephew. But we were waiting for my other cousin to come up from Virginia. And so I said, Ralph, I said, you know, you may want to try something a little bit different, or ask the doctor to try something a little different, because father's probably not going to make it to see Al come back, you know, come to visit.
Yeah.
And so, you know, they took my advice, and they waited, and they gave him something else that was a little, I mean, it didn't do everything with the pain, but it did some things with the pain. And able to see his son, and you know, they can go from there. But you know, these things, these are very complex, as you said. You know.
Yeah. Well, it's look at it from sort of the broader perspective, and I know that there have been a few documents over the years from the Holy See and elsewhere, from bishops' conferences and elsewhere, on how does one navigate the issue of pain management, palliative care, and those issues from the standpoint of church teaching. What are some of the basic guidelines for that?
Well, the ethical and religious directives speak to that.
Yeah.
Which would be something very good for the audience to have. You just download them, and they're very, very informative. But anyway, in terms of palliative care, Pius XII made a point to say that we should do everything that we can do to keep a patient lucid while managing their care. Which means that, you know, terminal sedation or some of the other things that they do that knock a person out. He didn't put a whole kibosh on it, because sometimes it may be necessary to to get to a person to a place where they're not lucid anymore. But in general, we shouldn't be going there. We should be doing everything that we can do to keep a person with their faculties as best they can, so that they could make amends with the people around them, that they could make amends with God, that they could receive the sacraments, that they could do all these things that will aid this person to go from earthly life to eternal life. And so we shouldn't be robbing a person from that. Now, obviously, there are going to be some cases where, you know, we don't have much of a choice. But in general, we should be prescribing enough to keep them as best as we can with pain relief. We're not going to get rid of it all, but we could then have to deal with the redemptive suffering that we've talked about before.
Yeah. So sort of flowing from that, that you have a loved one who's in a very difficult situation medically, and then the decision has to be made to remove them from a ventilator, or the machines are literally keeping them alive. As we have seen with other cases in the news, where do you start in assessing, in talking with your doctor about, okay, to euphemistically pull the plug or pull the ventilator, or how do you begin that? Because most people who find themselves in that situation are probably exhausted, they're upset, they're worried about making the wrong decision. It can be a pretty terrifying experience, can't it?
Well, it can be, and we went through that with my mother when she died some time ago. We had her on a ventilator, just the CPAP, that worked for a while. We took it off. She kept declining. We put her back on it. She kept take her off. She kept declining, and then the CPAP wasn't even working.
Mm-hmm.
So then the decision had to be made. Well, do we put a trach in or we don't?
Okay.
And in that case, where she was clinically, a trach would be too burdensome for them. We weren't even sure she was going to be able to make the surgery, so we just decided to let it go, and that's when we made a decision to just let death happen.
Mm-hmm.
But again, and that what I described was some time ago in bioethics, we called it the Peoria Protocol, where we which was developed outside of in Peoria. A guy by the name of Dr. Joe Piccioni put that together, and that was used quite often, to kind of wean people off of the ventilator when we have to. Another way of assessing this is to take a really good look at where she is internally with her, with brain waves and that sort of thing.
Mm-hmm.
But I think the best way that we could start is starting small with the CPAPs and seeing if we can wean them off and seeing how their oxygen levels rise or decline, and then just start now the process of looking at disproportionality, futility, and then going from there. Unfortunately, it has to be a process. This isn't something that we can make a decision overnight.
Right. But some of the terms that you've been using tonight, hopefully are of use in things to listen for as a patient and questions to ask a physician. But if you've talked a couple of times now about sort of end-of-life directives, of advanced directives, of living wills and other things. And as our time slowly begins to wind down here, one of the things that I really wanted to get into were those very issues, because we hear a lot today about the need for living wills, advanced directives. And first, what's the difference between a living will and advanced directives?
A living will is a legal document that is almost like a menu of some sort. I will check off. I don't want to be intubated. I want no DNR. I want this. I want that. I want the other thing.
Mm-hmm.
It's loaded with do's and don'ts of what I want or what I don't want.
Which to go back, which, as you advised, can be pretty perilous.
Oh yeah, and an advanced directive paints with broad strokes. I don't want anything heroic. I don't want anything that's going to be, disproportionate to my care. All those things that we talked about, because people can, in good conscience, say, do everything for me.
Yeah.
Do everything. Even if it's extraordinary, do it. I want it. Okay. Well, then that's fair enough. You can do that if that's what the patient wants. But that's what the caregiver needs to know.
Mm-hmm.
I want it or I don't want it. I want extraordinary or I don't want extraordinary. That way, the caregiver has a whole latitude of options for what's going to be the right and best treatment for the patient.
Mm-hmm.
But once you go with the check, the check says, I want this, I don't want that, I want this, I want that, you're tying everybody's hands.
Mm-hmm.
And not only are you tying everybody's hands, but you're not doing it in a way that's going to benefit you in the long run.
Right. And a physician is legally obligated to adhere to those specifics, right?
Not necessarily.
Okay.
We're bound to follow our conscience.
Mm-hmm.
And so if a physician is looking at an order that says, a living will, it says, do not, I don't want to be resuscitated. And he knows in all his experience in practice of medicine and all of his academic knowledge that this person's going to die.
Mm-hmm.
We could do something for this person. He's got to follow his conscience.
Right.
He must follow his conscience.
Yeah.
even the caregiver.
Mhm.
If the caregiver is not consulted first and sees this living will and it's got something on there that the caregiver finds totally immoral, that caregiver does not have to follow that.
Mhm.
Has to follow instructions.
And I'm suspecting that related to that is a physician-ordered life-sustaining treatment, or POLST.
Yeah, very, very dangerous. National Catholic Bioethics, no, it was the Catholic Medical Association put out a white paper on it.
Okay.
And
Well,
you can just
let's define that a little bit for everybody, and thank you for your patience. It's I'm standing in for the audience tonight and asking for definitions of terms because, as I said, so many of us who've been through this, there's a waterfall of terminology that just sort of hits you, and it's always good to stay with the basics so that we have some idea of what you're talking about. So when we're talking about a physician-ordered life-sustaining treatment, first, what do we mean by that?
you're giving the physician the authority to make medical decisions for you. And so what you're saying, and it's a document, you sign a paper saying, I give so-and-so the, Dr. So-and-so the permission to treat me in the best way possible.
Mm-hmm.
Now, a couple things wrong with that. First thing that's wrong with it is, how do you know Dr. So-and-so is going to share your values, your religious values, and your moral values? You don't know that unless you really do know that person,
Mm-hmm.
and know that he or she is, not going to do anything that's immoral from our vantage point.
Yeah.
In today's time, all we had to do is to look at the Alfie case and the Charlie Gard case.
Mm-hmm.
What are the hospital's financial resources have to play with this? And so now you have an 80-year-old man who's going in for some issue that he needs that could be easily corrected, but yet now you're giving the authority to the physician to do this, and maybe the physician is the chief of staff and doesn't want to spend the money to treat an 80-year-old when he could treat a 60-year-old. There's something not right with that picture.
Mm-hmm.
So again, I would never have anyone, if they ask my opinion, to go that route, because if you have a living will with a durable power of attorney, who you know and who you trust, let that person make the decision, not the physician. Now, again, the Catholic Medical Association has a great white paper,
Mm-hmm.
and you'll be able to read it. It's very good. I read it this morning, and it's very, very good.
Yeah. So it seems to me, and I'm not in any way making light of this, you really need to be careful what you put your signature to.
Absolutely.
Yeah.
Absolutely. And you even have to be careful with who is helping you make your living will, because most of the time people go to their attorneys. They do their last will and testament, and they'll do the living will, and it's a package deal, and that's all well and good. An attorney doesn't have the medical knowledge, in my opinion, that he needs to do this.
Mm-hmm.
And you really should have, some type of medical professional helping you with this,
Mm-hmm.
or somebody that knows, medicine, that could help you put together a good living will. So this way you're not getting, and also with the help of organizations like the New Jersey Catholic Conference or the Pennsylvania Catholic Conference, or all the conferences in this country.
And of course, NCBC, the National Catholic Bioethics Center, has a lot of documents. We'll come back to that in a minute.
Yeah.
But we've had a lot of discussion tonight about patients. We've had some discussion about caregivers. In the time that we have left, I'd like to ask you a little bit about responsibilities of caregivers. What are, from sort of a Catholic standpoint, the obligations and responsibilities of family in a particular situation? Because one of the things we're always hearing stories about the children of the elderly or sick who are not willing to have anything to do with their medical care, or in even worse cases, that are rather eager to see a loved one go for their own financial benefit, and yet it's sort of couched or hidden or camouflaged under the guise of, well, we just want what's best for them. What are some of the obligations, and what are things that we need to look out for as potential caregivers?
Well, first off, we had to look at what does Scripture say about this? What does the Ten Commandments tell us? Honor your father and your mother. Yeah. And it's not, and we could broaden that commandment, not just your father and your mother, but those persons who you are intimately related to that you need help with. Mm-hmm. So we have a biblical admonition to serve, the poor and the needy and the destitute. So that's, God's not going to look. We look at Matthew 25 and we see, that whole story about, I was hungry and you fed me. I was all these things, and it didn't go well for the goats.
Yeah,
it just didn't go well for them because they didn't do nothing of that. So, the faith calls us to be present to our families when they're in need, regardless if they're royal pain in the butts to you. They still need your care, and as best that you know how to give it. That's the keystone, I think, of Catholic social teaching.
Yeah, and for family members who are long-term caregivers or primary caregivers, or who find themselves caught up in a situation of having a loved one in these incredibly painful and difficult situations, what are some spiritual suggestions that you have, as well as emotional, psychological suggestions for how to not just get through this, but to really understand what you're going through? Again, that redemptive suffering, but also to come out at the other side of this without all the regrets and recriminations that often associate or accompany being a caregiver.
Well, allow me to answer this question with a personal experience. When my mother died, I'm Italian, and you know how Italians are with death.
Yeah. You said that, I didn't.
Yeah, trust me, I know. And after she died, I did not have that. I mean, I missed her and I was sad and all that stuff, but I didn't have that sense of, upheaval that most people do. And I was thinking about this about a few months later. I'm thinking, I told my wife, I said, am I this horrible person that I'm not like screaming and crying that my mom's died? Or she didn't know how to answer my question. But at the same time, I had to do a lot of soul searching and thinking. Yeah. And my soul searching led me to this, that I know that we did everything that we needed to do to make her death right. When she died, it was right. And I knew it was right. I knew it because of my training and as a bioethicist. I knew it in my life as a Christian man. I knew we did all that we knew how to do. And since my family kind of relied on me to make the medical decisions, I knew that I made the right decisions. And I knew that her death was right. So I could go through life atypical of an Italian son and not do the antics, because I had no need to do the antics. And so my thought is, when we're struggling with all these things and we have to work each day taking care of our loved one, if we're doing it with right reason, with right spiritual reason, with right medical reason, with all those things, it will pay big dividends after it's all over. Temporally and spiritually.
Well, and spiritually, which is, I think, really vital. So, I mean, it is the desire to see our loved ones to have, as the phrase goes, a good death. I mean, St. Joseph, we just had his feast day, is the patron of a good death. And how would you define, from a Catholic moral theological standpoint, a good death?
A good death would be one that was not caused, one that was as peaceful as possible, one that was surrounded by love and care, one that brings healing.
Mm-hmm.
Brings healing not just between the child and the parent, say, or the one person to the other relative, but healing with the survivors, that they can come together and
Mm-hmm.
see that, you know, we ran a good race, we fought the good fight. It's done now, and you know, there's an old Irish song that says, you know, let the road rise up to meet you until
Mm-hmm.
you know,
Right.
God bless you, and so that's a good thing.
I have a feeling that we could have just cut short this entire last hour if we had just started with that question, because in a way that answers everything we need to know in so many ways about end-of-life issues. So thank you for that. I appreciate that.
Yeah, I've often said that the foundation for the definition of good morality and good bioethics is love.
Yeah. And you don't always get that in an institution.
No, you don't.
Right. Well, we're just about out of time, Stephen. So where can people go? Where do you recommend they go for online resources? I know one of the ones that we've mentioned it several times is the NCBC, the National Catholic Bioethics Center, which I know you can find at ncbcenter.org, and they have a lot of publications, including, I think, a beautifully written guide to end-of-life decision-making. What other recommendations do you have?
Well, that would be my primary one, because you can get anything you want from there. But there's a there's a membership fee, but I tell you, it's not much, and the fee will give you all their resources. You know, the Catholic Bioethics, I mean, the Catholic Medical Association also is very, very helpful. You don't have to be a physician to join. It's cathmed.org. And they have, you know, access to white papers and conferences and various things that would be helpful to people. But I really do think that the go-to place is the NCBC.
Yeah, so that's ncbcenter.org if you're looking for information. Well, Stephen, we are unfortunately out of time. This has been a very helpful conversation, I think. I hope that all of you who are in attendance here tonight have also derived some benefit from it. Perhaps you're going to be leaving a little more informed. If any of you find yourselves in many of the situations that we've described tonight, do know that as a church, we are supporting you. We are praying for you. And I pray that some of the information that you've received tonight will be useful in making those sound prudential, but especially the sound moral decisions in light of the teaching of the church. Well, Stephen, again, thank you so much for being with us tonight.
This is wonderful.
Yeah. If you would like a lot more information on these types of decisions, but you'd also like to study more about theology, in particular moral theology, if you'd be interested in taking Stephen Boza's course on moral theology, which is a graduate course, please go to cdu.edu to explore our website for courses, continuing education, and all of the educational opportunities that are out there. That concludes our webinar for tonight. Thank you so much for joining me. I pray that you have a blessed May, a blessed summer, and a blessed rest of your year. Until next time, and our upcoming webinar, please stay tuned for that. I'm Matthew Bunson, your host for this evening. My renewed thanks to Stephen Boza, and on behalf of everyone at the Catholic Distance University, Please take care and God bless.
If you want to go ahead and unmute yourself, or if it gets too loud, then we'll mute again. So I do.
Thank you, Terry.
I see some questions here. Actually, yes, I think I will have everybody mute themselves, and then if you have a question or if you're going to talk, then you can unmute yourself. But it looks like for now, so Angie asked, is it better to do a living will over an advance directive?
Personally, I think an advance directive is much more superior than the living will. And I say that because it gives your healthcare proxy a wide range of options. I think the only thing that's important at this time is what we said in the webinar. You know, do you want everything done for you? If that's something that you truly desire, then that's something that's your right. But that has to be known. That has to be made known to your healthcare proxy. If you don't want disproportionate care, well, that needs to be known. But what is disproportionate care? It would vary from me to you to anyone else because of who we are as individuals and our bodily needs and medical condition. And so because we vary in the types of medical conditions that we have and the type of bodily systems that we have, then we need to give our physicians and the healthcare proxy as much leeway as possible. Now, if you go into this situation with a living will, you're directing the action to be taken or not to be taken, but is that in your best interest? And what we found is that oftentimes it's not in your best interest. Does that make sense?
Mm-hmm. Does anyone else have another question along those lines, like about the advance directive? It looked like Barbara said the Archdiocese has an advance directive form that you can find online. So at Arch Atlanta, I guess.
I think many dioceses and archdioceses have samples that could be used. And again, you could find them on the NCBC website. They have some living wills too, or advanced directives as well. So yeah, I mean, your diocese or archdiocese should have it.
I'm going to put that website in the chat. So it's ncbcenter.org.
Yes.
.org.
ncbcenter.org.
That's a good one. And the next question.
I have a question. I wanted to share that my Franciscan fraternity, we had a 1 week where we spoke about death and dying issues, and they're the ones that handed us out the forms for the healthcare directive. And it was amazing how many people were really ignorant as to what they were. And a lot of people thought they had to go to a lawyer to get one and that it was binding. And people didn't realize that you can change it. I mean, it's not in cement. I mean, once you fill this out 2 years from now, you may have changed your mind. So it's something you can go ahead and change. You just need witnesses. It's not something you need to have notarized or anything. But a lot of people think that they have to go to a lawyer or something like that, where it's much simpler than that.
I was happy to hear that it's according to the conscience. So if you, in that situation, you don't have to, if you feel like you said, Professor, that if something on that that advance directive or that living will doesn't seem right, you don't have to stay faithful to that if you think something much would be better for the person, right? That you have the freedom
Yeah,
to.
that's really important. I mean, a lot of I've had a student one time talk about her mother's living will, and she realized that after taking the bioethics course, she realized that what was on there was not moral. She goes, now what do I do? And I said, well, you have to follow your conscience. And she at first objected to that because she didn't want to not give her mother what her mother wanted. And so it took a little time to unpack that for her. But my recommendation is that if you designate so-and-so as your healthcare proxy, or the person who would make the decisions for you, it would be extremely valuable for you to take that living will to that person and say, this is what I'm asking. This is what I want. This is what I don't want. And be direct with them. Could you live with this? They may say yes, or they may say no. If they say no, then it would be tremendously advisable for you to find another healthcare proxy. And you could do that. So I think transparency is important for that person, but I also think this person has to always obey their conscience. And if you do that, if you do advance directive, I think you avoid a lot of that. It's with the living will that you run into issues and difficulties.
Okay. Another question from Chris. Have you heard of 5 wishes? The booklet where the individual fills out 5 sections related to naming a person you want to make medical decisions, the kind of treatment you want or do not want, your wish for how comfortable you want to be, your wish on how you want people to treat you, your wish on what you want your loved ones to know. What are your thoughts on this? Seems like a combination of advance directive and living will.
Well, my comment is I don't have a comment, actually. I don't know much about the 5 wishes. I've heard about it, but I've never really explored it. From my vantage point, I think it's more important for us, people of faith, to kind of take the living wills or the advance directives that are put out by our church than to do something like the 5 wishes. Now, I have nothing against it, but I don't have anything for it because I simply just don't know about it. But I think for all of us, I think it's important to follow the lead of the church and use the things and the tools that they give us, because those tools have been vetted by theologians. Those tools have been given the blessing of the local bishop, and quite frankly, that's very valuable for us. It's very, very valuable to have tools that have been given their imprimatur, if you will, by one of the successors of the apostles.
Does that answer your question, Chris?
I mean, please feel free to ask follow-up questions or talk to me about that or anything else, because I see this as a conversation. I mean, we have to be realistic and know that 37 people have a difficult time having a big conversation, unless you're from an Italian family and everybody talks at once. But we should really, I would suggest that you feel free to respond to my response if you feel you need to.
All right. No, I respect that. I just wanted your opinion on that. One of the things I liked about that was it also talked about specific things, about as it gets closer to your dying process, how do you want people sitting with you? It goes into specifics besides just the medical issues,
Mhm.
and then down to what do you want to leave with people? What do you want them to know? So I like that part of it. I just didn't know if you'd heard of it as far as the actual medical choices you make or don't make. And
Yeah, yeah,
think-
I would have to look at it to see.
Mhm.
I'm sorry.
No, you're good.
And Chris, is this your second question? What is the Catholic Church's stance on cremation?
That has changed. It used to be that, they didn't allow for cremation. But in modern times, and when I say modern times, I'm talking probably in the 60s and 70s, that's really modified. A person in good conscience could seek cremation. The only stipulation that the church gives is that the ashes need to be buried. You can't be cremated and then decide that you're going to throw the ashes on the in the animal reserve, or throw the ashes, in the lake. I mean, if you want, an aquatic burial, then the urn that the ashes are in should be treated as if they were going in the ground, but instead they're being weighted and going into the sea. So we have to be respectful and give due respect to the ashes, because that's really the body. So with some of those caveats, the church doesn't frown upon cremation anymore.
What about, I've had this question come up. What if somebody expressed that they wanted their ashes to be scattered? And is this one of those situations where your conscience, but they've died, and you're making the decision of what to do with the ashes? Is this one of those times when your conscience could allow you to make a different choice for them?
Well, again, that goes, the person who's asking me or you to make those decisions really need to tell us what they wish. Okay? And at that point, they could choose someone else if they see that we don't agree with that. But it's the same principle. If you don't know what this person wants of his or her ashes, and that's what's requested, then I either have to give it to someone else, or I have to give it a proper burial, because that's what my conscience tells me.
I know that I've had people ask me because they wanted to bury their loved one's ashes, so there was a place for them to actually go to pay respects or to visit, but the loved one had requested the ashes to be scattered, and they were struggling with that decision.
It is a struggle, but as a faithful son or daughter of the church and of God, basically, we are required to respect the body, even if it's a cremated body. We need to respect those ashes. And I know you didn't ask this question, but it leads me to this. Well, then someone had asked me, I mean, could I donate my body to science? Well, the answer to that is yes, for a specific purpose and for a specific period of time. So if you're a cancer patient and you wanted to help find the cure for this form of cancer that you have, there's no moral difficulty with allowing the researchers to research on this pathology and in your body. But that's not open-ended. That may take a couple of weeks, that may take a couple of months. We don't know that. But after that period of time has expired, that body needs to be buried in a proper Christian burial. Does that make sense?
Mm-hmm. Yep.
Terry, can I ask a question on that quick then? So I've studied to be an end-of-life doula, and I see myself working with a lot of our Catholic population, so I want to make sure I understand the right and wrong thing. So if someone says, I want to donate my body, then it has to be specified somewhere, like in their advance directive maybe, or in their will, or like, how do you specify the amount of time that someone can have? Like if I'm
I think she froze for a second. Yeah.
She froze, yeah. Well, let me try to answer that question from what I know of your question. I think we have to, you're back on.
I'm back. Okay.
So what's the rest of your question, or were you finished?
I don't know where I cut out, but I just want to be able to give people the correct answer. If someone says, I want to donate my body to science, to whatever, is that then in their, maybe their advance directive, or, and do they say you can have it for X number of weeks, X number of months, you can have it until you're done researching this part of, I mean, how do you specify that, I guess?
You would have to ask an attorney. But after you've gotten the proper answer from the attorney, I think it has to be specified that, yes, you could research on my body for whatever it is that you need, but you do have a time period, and it's extremely important that the body isn't isn't mutilated. You know, I mean, you can't just say, well, you know, you can't mutilate the body even for science, but you could extract the organs, or you could do the other things that you need to kind of get a read as to, you know, what the problem was, what the pathology was, how did it start, all the various and sundry things that the researcher really needs to know for the advancement of human health and well-being. But there has to be a limit to that, and it's up to the individual to say, you only have X amount of time to do this.
Okay.
That has to be specified in whatever document the attorney says is necessary. And then it needs to be buried. No, then it needs to be buried.
That's kind of goes to the issue of when they use aborted fetal cells in different medical, the vaccines. It's come up a lot with the vaccines. They were saying that that baby needs to be buried and not continually used for research, right? Isn't that kind of along those lines?
Well, that goes to there's so many nuances in all that. For instance, Johnson & Johnson makes their vaccine through the stem cell lines that have gone back. They could go back decades, but they're using these lines specifically to manufacture the vaccine that they want to do. Well, that's a utilitarian understanding of the human person. You can't use one person's body parts for the health and well-being of somebody else. You can't do that. And so therefore, we shouldn't be making any type of pharmaceuticals with aborted fetal cells. We shouldn't. Now, having said that, if you've been keeping up with the news, Johnson & Johnson's is the next vaccine to go for FDA approval. It only has a 65% effectiveness rate, where the Pfizer and Moderna, who were legitimately made, have a 95% success rate. So, you know, it's very stark. You don't need to go that route. I remember back in the 90s when there was a very strong effort to use stem cell lines from aborted fetuses in stem cell research. Two things happened. The first thing that happened is it doesn't work because those lines are unpredictable, and they mutate to the extent that they mimic cancer cells. No venture capitalists would put their money into such a research. It wasn't happening. Then the governor of New Jersey had this brainy idea to put it on the ballot initiative just to get the sucker taxpayers to pay for something the venture capitalists would not. As it turned out, New Jersey Catholic Conference did a really, really good marketing job, an advertising job. That was one of the very few ballot issues that was defeated at the polls. It doesn't work. So science is on our side with this. You know, we had to be diligent still and reject any vaccine or pharmaceutical use made from aborted cells, but at the same time, we're being helped because they don't work. You follow what I'm saying there?
Yep. Another question about burial. Somebody asked, is it okay to keep ashes in your house?
No, they have to be buried.
Okay.
I mean, that's as definitive as you can get with that. They have to be buried.
That's good to know. And Dolly asked, what is the best way to spread the news about Catholic teaching regarding this issue?
Cremation?
No, I think, Dolly, what were you talking about? The whole concept of?
Right, the whole all the life issues we've been talking about tonight.
Well,
I feel like most of us get our theological perspective from watching the medical dramas on TV, which are not necessarily accurate or truthful, and usually portray a perspective that is not supported by the Catholic Church. So, you know, what do we do?
oh, that's a great question. I think what we do is we need more forums like this. Now, I'm not sure about how things work in your diocese, but I know when we do this in Philadelphia, we start preaching to the choir. Because, you know, if you're typical of the other dioceses around the country, you're already convinced of the truth of the church. You're already convinced. You know, and so this is something that's more of an enrichment, maybe more of a way of learning more about certain things. But for the average person, they don't. And, you know, people approach the church in times of crisis, if they do at all, you know. But we all have neighbors, and we all have friends, and we have to find a way that's unique to us and and unique to those persons that you need to spread this message around to, in a way that's going to allow them to embrace you and not be repelled by you. So I know I'm dancing around the issue because, frankly speaking, this is a problem. We need to do this. How we do this, it's very elusive to me. You know, but you know, you have your way of spreading the faith that's unique to you, Dolly. And whatever that way is, then I think that you need to have the courage to use it in a way that's unique to you. You know, I've often found that people, when they're hurting, need some, and when you have these issues, you know, of people of end of life, they're in a tizzy to begin with, and your calming voice and your reassurance and your heart-to-heart communication means everything. And I think that we have to look at those scenarios in our lives and say, okay, how am I going to bring that message of hope in a way that they can understand, and in a way that only you can give, or you, Kathleen, or you, Terry, or me. There's certain things that only us can do in our own way. Does that make sense?
Mhm.
So what does that mean? How do you understand that? How do you understand what I said?
Well, for me, it means living a Christ-centered life and really developing a communication with the Holy Spirit and start living as if I'm led by the Holy Spirit, in compassion and love, and not to, like you said, not to be afraid, just to say what you need to say.
Yeah. And I've happened upon this webinar. I think Bonnie found it. She got an email about it. She sent it to me a while ago, back in 2018. And I thought it was so good. So you guys will have access to this video too tonight, and you can share it with people. And, one of the ladies left, she said she wanted to have access to it so she could stop it and write something down and pay attention to it. That's what I did through it the first time. It's such great points. Like the question at the beginning where he said, asking the right questions is so important. And so like, is my mom in the state of medical futility? Just knowing that right there and what that means, that most people would appreciate that information. I think anytime we share this, it's going to help people no matter what. So this is one resource.
Yeah, I think that we have to be bold, but yet respectful of our physicians. We have to be able to challenge some of the things that they say, not in a bad way, but in a way that lets them stop and pause and think, okay, this person needs a little bit more of my explanation. And so I know, and I can tell you, I had relatives that if the doctor said X, that word was gospel. I know a person, I absolutely know a person that was told that, she had a lump on her breast, and the doctor said, oh, don't worry about it. We'll see how it goes and we'll keep an eye on it. And when she told that to me, I immediately came back and said, lumps don't belong in breasts. You got to do something about this. And she didn't. And, and then it got worse, and it didn't have to get worse. And so, our physicians are good. We may like them. They may have given us good treatment, but they don't know everything. And you're not being arrogant. You're not being a smart person by saying, you gotta be kidding me. What's this all about? Give me a reason why I have to follow your advice. Maybe our parents and our grandparents could accept paternalism in their healthcare, but we don't have to do that. We don't have to do that. We need to say, this doesn't sound right. You need to explain this. And if they're not willing to give you good information, well, then maybe it's time to think of finding another physician. Long gone are the days of paternalism. How do you feel about that, everyone? How do you feel about that?
I think it's I am a 2-time ovarian cancer survivor. And I have had at some point to be my own advocate and question what was going to be done. And I was very fortunate that I had a very great OBGYN oncologist. But I've been a caregiver too, and I've worked with people who would take the doctor's word as gospel and not even ask what type of chemotherapy they were going to get or how long it was going to take. They would just depend totally on the doctor's decision. And you can't do that nowadays. And I respectfully, like you said, question. You have the right to question and get a second opinion even. And I think a lot of people, you know, from my generation, my mother and my grandmother, whatever the doctor said was, you know, that's what you did. And we have so much information out there now that we can find out things on our own. And I encourage people to do it.
Yeah, and this is not to, and I'm sure, Barbara, you're not doing this, and I'm not either. We're not demonizing our physicians because they're good. They have much more knowledge than we have. And, you know, we wouldn't be going to them if we didn't have, you know, if we didn't have confidence in their abilities to treat us medically.
Absolutely.
So this is all good stuff, but they're not the Messiah.
Exactly.
We only have one Messiah. And so we need to respectfully challenge, respectfully ask questions. And if it doesn't sit right with us, then we need to ask more questions. You know, it's not something that, you know, it's the questions that we ask and the need to ask questions that are going to allow us to get the best care for ourselves and our loved ones. And so when we couple that with good, solid Catholic bioethics, we'll be in very good shape.
Absolutely.
You know, we'll be in very, very good shape.
Can I add something to that, Terry, just quick? So I see sometimes the opposite in healthcare. I do home health physical therapy. And I see sometimes that the physicians kind of push the patients to do every last possible. And of course, we want to do whatever the church expects us to do, right? We want to try everything. But I see some people whose end of life is so, there's so much, they're in the hospital and there's pain and it's not a beautiful ending, a beautiful transition to their new life. And that's why I'm trying to feel out what does the church call us to do? And then when is it time to say, the church doesn't, you don't have to continue on this path. Maybe if you say, I'm done, I'm in a frail position and I want to enjoy what time that I have left with my family and complete things that I want to complete. So I see kind of both sides of that. Does that make sense?
It does, because a lot of times the physician's identity is wrapped around the ability to heal people. And that's very, very noble. Sometimes they can't. You know, sometimes what conditions that we find ourselves in are beyond what a physician can do for us. And sometimes I think that they want to try everything. And that's a really good trait that they have. But at the same time, we have to always look at that balancing act. You know, do all that we can do, the best that we know how to do it, and come to the understanding that we knew what we can do, we did the best we can with it, it's not working, and so now we have to accept the fact that we need to now start the palliative care, you know, and get a person, you know, as comfortable as we can get them in a good place where they could be surrounded by family and then allow God to be God.
Amen.
You know what I'm saying?
I liked how you said to try to keep them as lucid as you can so that they can make amends, so that they can repent or whatever they need to do in those moments.
Right.
That's a beautiful thought. I have a question along Chris's lines. You talked in there, and Matthew talked in there about different types of care. And at one point we were talking about the ventilator, the feeding tube and the hydration. And then he brought up the ventilator. And aren't those in two different categories? Is one considered normal care and one not normal care?
Well, the feeding tube is normal healthcare, is normal, care for a patient until you get to that place that we outlined in the webinar. Now, respiration is a little different. Respiration depends on your body's ability, your lungs' ability to breathe, to that part of the cerebral cortex that deals with reflex. Breathing is a reflex. We don't think about breathing, we just do it, and so it's in a different ballgame. It's in a different ballpark. And if your body's not going to be able to breathe on its own, then the only options that we have is the trach, which is valid for some. It wasn't valid for my mother, but it could be valid for some people. But then we have to ask the question, are we prolonging, the dying process in this person? And unless we, are really involved with this person's health and their attending physician, we don't know the answer to that. But when it comes to a place where they're just not going to be breathing on their own anymore, then we should start thinking about not having it. Whereas food and nutrition is a different ballgame, because look, you could take you could take the ventilator off and a person will die in 12 hours, maybe 8 hours, 6 hours. You take a person off of food and water, and now you're dragging this person's death for weeks and all the pain that goes with that. And again, food and water is normal, ordinary care. It's what people need, whether they're in utero or whether they're in any stage of their life. They're not going to survive without nourishment. So that's why we can't look at food and water as medical care, and we can put that in a different category from ventilation.
Okay.
Does that make sense?
Yes, absolutely.
Can I ask a question, please?
Sure.
Yeah. I understand what you said, and I agree with what you said just now. But when you talk about a feeding tube, it goes up your nose, it goes down through your throat, down your esophagus, into the stomach. And, it's not real comfortable to have that apparatus down there. I mean, you can have water given to you, you can have an IV fluid, but I'm not a big fan of those feeding tubes. I mean, I don't want one. I know I don't want one, because I would gag when that tube, and most people do gag.
Well, there's more than just one form. There's the PEG tube, where you have something inserted into your stomach. So that's another option. So I think it's important to lay out all the options. I mean, sometimes, the nasogastro tube is, uncomfortable. But the question is, how permanent is that for an individual? If that's not going to be a permanent thing, well, then that's something to consider. If it is going to be a permanent thing, that they may want to consider doing the PEG tube. But then that's that person's decision, that's the caregiver's decision, but a PEG tube bypasses all that.
Okay.
I guess my question would be, does a Catholic have the option of saying, I don't want a feeding tube, no matter what?
Not really.
Well,
Yeah.
if we're looking at the understanding of ordinary care, then we're all obliged to avail ourselves of ordinary care. Question comes, is the nasogastric tube ordinary care, or is it extraordinary? I don't think you can make a case that it's extraordinary, because it happens all the time. So you can't make the case that it's extraordinary care. If it was, as some of the Jesuit consortium would say, that it's a medical act, that's an erroneous statement. It's not a medical act. It's you know, even though you have to use medicine, I suspect, to, you know, put the feeding tube in your nostrils and down into your stomach, or you have to go into minor surgery, and it's not even minor surgery. It's something even a little less than that, to insert the peg tube. You know, the act of feeding somebody is not a medical act. So my thought is to, you know, kind of think about all of that to answer your question properly, and also to know what's the circumstances surrounding this. That's the big thing. I mean, you know, if someone's going to say, well, I don't want to be intubated and I don't want any of that stuff, but if your physicians are telling you this is not going to be very long, it's going to be, and you'll live a very, very good and flourishing life, you know, you may have to go through this for a couple of months. Well, that's something to think about. You know, that's something to think about. If this is going to be something that you're going to have to do for the rest of your life, then you have some other soul searching to do. You know, I would recommend that when you get to that place, that you consult with the National Catholic Bioethics Center, because they would have more information to give you. You know, I'm giving you what I know and what I see, but it's always good to have that extra voice, you know, that's going to help.
I had to make that decision with my mother, who had Alzheimer's and had pneumonia, and they wanted to put a tube in, and I knew that if they put a tube in her nose, she was going to pull it. She was 91. She was pretty much in and out, and they wanted to do a peg tube, and I knew that if they did that, she might not survive because she had respiratory issues and everything else. But she was able to take things by mouth a little bit at a time, and that's what we did. The doctor was very frustrated and very angry. What was interesting was that I spoke to a speech pathologist who told me that if she was going to aspirate, she was going to aspirate even with a peg tube. So it made it very easy for me to just say, okay, I can just give her little sips of food and just let her not have to go through the struggle of having tubes and having to go through her pulling them off because she was out of it. And that's a very hard decision to make. And I don't ever want to make that decision again.
Well, you know, the answer, or not the answer, but a response to your question was already talked about. I would recommend that you listen to the webinar once again, because basically what you're describing is disproportionate in terms of burdens over benefits. Now, if you look at everything you said to me with this understanding of what you heard in terms of benefits and burden, you're going to probably discover that the idea of her pulling it out of her, and at her age pulling that out, you're not going to change their mind. She's going to do it. Well, then that presents a danger to her, and presents a tremendous burden for her. If the person you spoke to said that you could still aspirate, well, then again, you go back to benefits and burdens. And that's a risk that doesn't need to be taken. So, you know, we all like to, number one, be comfortable with the decisions that we make. But if we look at it reasonably based on what we've heard tonight, you're going to find that your action was justified. And in terms of Jan's questions too, it all goes back to, you know, how is this going to affect the rest of your life? You know, and only you guys could make those decisions for yourself. But if you look at everything we spoke of, then Jan would have the answer to her questions. You would have the answer to your questions, because it all fits. It all fits in. And as much as we like to paint with broad strokes, we have to let those strokes be in the background so that we can make the best decision based on our who our medical conditions and the surrounding things that are happening to us, either personally or to a loved one. Does that make sense?
Yes.
I think your discussion too on benefits and burdens is helpful to people that are struggling with the right to life. Because I know my own mom, who was very frail, this was some years ago, and she had a progressive neurological disease and she was paralyzed, and she was a very strong Catholic, and she believed very strongly in right to life. And in her mind, that meant she couldn't do a DNR. And
she could or couldn't?
Could not, because she would be taking her life by saying, I want to be a DNR. And she finally had someone from the church come and explain the difference. But the way you explain kind of benefit and burden is helpful to know that we really aren't called to do every last thing, and we can still be considered right to life. So that's helpful, what you explained.
Very helpful. Pedro, you had a question about how is the advice for parents with kids in college regarding medical directives? Do you want to explain your question?
Well, yeah, since we're talking about, kind of making the decision of in advance of what we want to be done on us in case of a medical emergency or condition, my question is, okay, is it probably a good idea, to have the same discussion with your kids, especially the ones that are away from your house and they are old enough to be considered legal adults?
I think it's always good to have conversations among adults in our families. For instance, I'll give you a bit of a insight as to my wife and I's discussion on living wills. Now, I've been in this business for 20 years. She knows what I know basically because she had to live with me for 20 years or 30 years. And so we know what the ethics are. So she'll know if I'm in a bad way, she'll know, what, number one, what was the right thing to do, and number two, what is I would want. And I would know that for her. And so we could be very confident that we'll do the right thing. Now, the thought came to me is, okay, well, what about if we're out someplace, we both get in a car accident and we're together? Now what do we do? So I'm thinking that it would probably be right now to put a living will together for ourselves, or advance directive. I wouldn't do a living will, and then share that with our son. Now, that's our decision because we see and we could foresee that it may not go the way we think it's going to go. Now, for kids that are in school, first off, kids that are going off to college, that most of them think they're invincible, nothing's going to happen to them. And we know that that's not true. I think as a parent, it's important to enter into these discussions, with our children that are away from home, so that you could get a sense as to what's going on in their mind, and they could get a sense as to how you will direct their care, because they're not married and you guys are the next of kin. And so I think it's really important to have that conversation. Now, whether or not you need to go the direction of an advance directive is another story. I can't answer that question, and I wouldn't answer that question because that's up to the individual involved and it's up to the family. But I think what could be helpful is for you guys to have heart discussion so that you get a sense of where they are or where you are for them, and then you can just have that, you know, so so that you can have an idea as to what's in their hearts if you're ever called to make these decisions. But again, you make the decisions based on your conscience and what you know to be right. So if a young adult says, oh, you know, just let me go, I don't want this, I don't want that, I want the other thing, and you're there next to kin and have to make their decisions, my response to that would be, well, thanks for letting me know. Then I'm going to do what is morally right for my child. You follow what I'm saying?
Yes, thank you.
You're welcome.
Another question is from Angie. She said, what is the PMDD, Protective Medical Decision Directive? Is that the same as an advanced directive?
Frankly, I've never heard of that. So if, Terry, if you could email me that, I'll do some research and I'll get back to you.
Okay. Okay, this next question, this is from Chris again. Can I confirm something you said? The POLST is allowing the physician to make the decisions. I had thought it was a form the patient fills out making their own decisions and the physician then must follow it, similar to a living will. I don't think I understood it correctly.
Yeah, you didn't understand it correctly, because the physician authorized life-saving treatment says that you give your physician permission to make these decisions for you.
Yeah, I didn't understand it right, so I'm glad you cleared that up.
Yeah, you don't want a physician as I mean, my primary care physician, I know him, I love him, you know, he knows me, but I wouldn't entrust that to him. You know, I just wouldn't, not because I didn't like him or I didn't think that he would do what I want, but that's number one, that's not his role. And number two, am I really correct that he shares my values? I don't know the answer to that question. So I personally, and I would have some good voices to back me up here, I don't think that that's something that we should ever take advantage of. It's just dangerous.
Okay, Chuck is asking, if you agree to be the healthcare proxy for a family member or friend and understand their wishes about end-of-life care, what are your responsibilities, if any, if you start to have concerns about their health behaviors like overeating, drinking, drug or alcohol use, etc.?
I think there's a lot of questions inside that one question. Now, I'm not quite sure I understand it fully. So you're the healthcare proxy for your brother. Okay. And you had to make these decisions, but then again, you see them making choices that are harmful to them. It's none of, in my opinion, it's not something that we need to say, you need to stop drinking, you need to stop smoking, you need to lose some weight. That's not the role of a healthcare proxy. If those are the things that this person does, well, that's what that person does. As a brother, you could, you know, give some paternal advice that this stuff isn't good for you. But I think that that's where it ends. No. A healthcare proxy isn't meant to dominate a person's life. A healthcare proxy is to make decisions, medical decisions for them when they can't make it themselves. And does that make sense?
Mm-hmm. Does that answer your question, Chuck?
Yes, ma'am.
Yes, that did. Thank you.
Thank you.
Makes perfect sense.
Okay, let's see. Any advice on finding a good Catholic attorney that can guide us through these steps?
Well, if you have St. Thomas More Society in your area, that would be the first place I would start. You know, and I'm sure you're, well, yeah, I would start with the St. Thomas More Society. I mean, you could probably go to the Knights of Columbus. I'm not sure if they would have access to female attorneys, but they would certainly have access to good Catholic attorneys that are male. I mean, that's one place to start. So if you don't have a preference, then Knights of Columbus would be, you know, helpful because they may have their fingers on a few people, some members who may be, you know, attorneys.
I just know that there's some attorneys that don't quite understand to the extent that you have led us and that we should research, that may not direct us, and they may not ask the same questions, or you know what I'm saying?
Yeah. And again, I don't want to disparage attorneys because they do a good job,
Right.
but I don't know if they're the people that you should start with to get a living will going. You know, you don't need an attorney to draw up a living will or an advance directive. You need a witness, and that witness doesn't have to be an attorney. You get it notarized, and that notary doesn't have to be an attorney. So you're much better served by going to your family physician, going to, you know, a nurse practitioner or some medical professional that shares your values, that could help guide you in some of this stuff. But really, the reality is that I think if you know the bioethics, you could do this yourself. And, you know, you all have access to this webinar that you just heard. You all have access to, you know, the National Catholic Bioethics Center. You have access to a lot of resources that could help you,
Okay.
you know, do this.
Thank you.
You're welcome.
Two more questions. Teresa asked this question. I've seen people in the last days of their life quite naturally eating less and less. You wouldn't insert a feeding tube in that case, would you?
Not necessarily. Because if they're eating less and less, it's maybe because their body's shutting down and they're moving towards their natural end. You know, and so I don't think, again, you have to look at the whole case. You have to look at that person. You have to look at everything that person is going through. But it would seem to me that when they get to that stage and they're just not eating, then, you know, their body is starting to transition, you know. So again, you have to be vigilant. But I wouldn't be too concerned. Well, no, you're always concerned, but I wouldn't necessarily move towards the feeding tube in that regard. But again, you have to know all the facts.
That's the clear thing that I got from you, especially that every case is different. We can't take generalizations and apply them concretely to every case.
No, you can't. You just can't do it.
Vi Martinelli.
There's a role for.
What did you say?
No, I was just going to say there's a role for pragmatism in bioethics. We need to be pragmatic. So I'm sorry.
No, I was going to say the next question is from Vi. She said she's the healthcare proxy for a non-Catholic who has requested cremation and requests for her cremains to be scattered. What moral position is she in, or what moral position is she in? Sorry, I can't see this. What moral position is she in? She asked a deacon, and he said that she was obligated to honor her wishes.
I don't think the deacon was correct. I think that if this person, this proxy, knows ahead of time what she's requesting, then that person has the moral responsibility to say to this person, I cannot do that. It will violate my conscience. And so that would give the person the opportunity to say, okay, I'll find somebody else, or give that person the understanding that that's not going to work. If you want me to be your healthcare proxy, I will not do that.
Is that okay, Vi? Is that?
Now, how do you guys feel about that? How do you guys feel about that?
She has,
Answer.
when she talked with me about this, she was of sound mind. And she did know my position. And at the time, she knows my position and she respects my Catholicity. But she feels strongly about cremation. And of course, I didn't have the guidance at the time to say what you had just suggested. So I spoke with the deacon. And as Terry said, he said, I'm obligated no matter what she asks to do, what she wishes. But now she has dementia. And I don't believe she would be able to answer me with sound mind.
Well, if she's just asking you for cremation, then yes, you could do that.
I understand that. And that's what you said when you addressed the, as a faithful son or daughter, that we have the moral responsibility to bury, which I understand that with cremation too, but now I felt confused thinking about this woman that I'm responsible for. And there aren't any other people in her life for her to ask.
Well, I can only say what I would do. I can't say what you should do. I will say what I would do. It would violate my conscience to spread her ashes in a rose garden. And I'm not ever to violate my conscience.
Well, no, please continue.
And in this instance, she doesn't have anybody else. My initial thought would be to bear the expense of burying her body. That's my initial response. I most likely would stick with that, but you may be more helpful to check out another ethicist on that and call the NCBC to ask them that question, as well. And then, go from there. But, just because somebody has something in their living will does not mean that you are obligated to do that. And I don't think that was the correct response from the deacon. I think that your first obligation is to your conscience.
Well, thank you for this clarification, because that's just how I've been inclined to think. And I've actually been in, I won't say turmoil, but it has been a dilemma for me because I want to do the correct thing according to the church. That's why I went to the deacon to discuss this. And then after listening to everything this evening, I'm just so thankful that you were available for me to ask this question of you. Yeah, she asked to be scattered in a state where she used to live for several many years. Nothing specific, and I wouldn't feel right doing that. But after the deacon said I'm obligated, I thought, okay, well then that's what I obviously must do. But
you're obligated to your conscience.
Okay. All right, thank you.
And
Now,
if you're
if
con-
oh, please go ahead. I'm sorry to interrupt you.
I'm just going to say, if your conscience is troubled for this, then you should not go there.
Okay.
Now, this will cost you. It'll cost you some money to find some place where she could be buried. To bury cremated ashes are not expensive, but at the same time, I'm sorry.
I was just going to say, Professor, that won't be an issue. I'm just wondering now, should I decide to bury her here locally because she's local, or she's requested Texas, or bury her in Texas since that's where she has to be scattered. She was deciding between Montana and Texas, and then she was last saying Texas.
Well, you could accommodate her wishes by burying her in Texas. I'm not going to go as far, yeah, and I would go as far as saying that this is what her wish is, and that's what you ought to do, as the deacon said. But you would have to find an appropriate burial ground for her.
Mm-hmm. Here, I know of an appropriate burial ground. There, I would have to. It would take some research, but I would be willing to do that. I just appreciate you guys.
Yeah, this is something that you would have to determine, and make the best decision that you could find on there. The guidance that I could give you is follow those directives as best you can, but those directives that violate your conscience, you ought not obey.
Okay.
So if that means to take a couple of weeks and find a suitable place in Texas, well then, in some regard, that you ought to do that.
Okay.
But you should never violate your conscience.
All right. Thank you so very much. I really appreciate you.
You're welcome.
Oh, and to the listening audience, regarding the question about the 5 wishes, and I just wanted to share that we had an experience with a family member. I have a brother who's now deceased, and he was involved with one of those documents. And we were told that it was, or I actually was told prior to my brother being involved, this woman I take care of, she actually started her advance directive with that because her financial advisor told her they were legal in Georgia. So with that being said, my brother, who was out in Omaha at the time, got involved with 5 wishes, not because I suggested it. He had learned about it out there, because I still was not quite sure about how I felt about that. I'm familiar with Pulse document and etc. In any case, he did write out his 5 wishes, and it does need to be notarized, but his was not done properly. Apparently it was signed on the day it wasn't notarized, but in any case, it caused a lot of confusion. He was in the ICU unit, and it was causing a lot of confusion with his medical team. Even though it was legal, the way he had it written and stated, it was just very problematic. And so I knew then that I would personally not get involved with the 5 wishes. Some people have described it as a warmer and fuzzier document, because you can state, I would like for the rosary to be prayed by my loved ones, etc. You can go into all that with the 5 wishes. But the advice I heard from you and in the webinar just seemed to be more assuring, just getting those documents from the Archdiocese or from the Catholic Distance or wherever. And I want to be sure of the abbreviation. Is it NCB as in boy, or D as in
National N, Catholics, National Catholic Bioethics Center. So it's N, National, C, Catholic, B, Bioethics, and C, Center, which is spelled out.
Okay, thank you. Okay.
That's all the questions that I have. And unless I missed somebody's.
Well, I tell you, this has been a pleasure for me. I'm so grateful to be invited to do this. I would ask you to think about, if you want to know more about the intricacies of bioethics, to consider taking one of the courses that we have. That's that 4-week course from CDU. I think it'd be very helpful and informative to you. If you're going to do that, CDU will set up a course. I mean, you can take certainly one of the Beacons courses because the content's the same. But if there's a number of people within this audience that want to take it, then we could get a course directly for you. And you just have to let me know. We'll get it set up. And, it could help you on your journey. So as long as I have 5 people, we could set up a course. So
Okay.
you guys think about it, talk to Terry. If you want to do this, I will certainly work to accommodate you.
I want to say one more thing. Hope has a question.
Yeah, Terry, do you want me to just ask?
Yes, go ahead.
So thank you for all of your wonderful advice. It's been very informative. So I'm very early on in my medical career, already confronting a lot of these questions with my colleagues who do not share my views or values. And of course, I immediately turn to the catechism and pair that with my bioethics textbooks. But how do I reach, I guess, my colleagues and peers that are really rooted in the biology side of answering these questions and not so much theology? I guess, how do I confront and kind of approach these conversations with them?
I would use science. And this is what I mean by that. Let me give you an example. Natural family planning is not something that you could sell in marriage preparation very well. And when I teach nursing students, and we get to that place, you could just see the, you could just see a turnoff. They don't want to hear it. So what I did was change the whole dynamic of it. So now in marriage preparation in Philadelphia, and when I teach secular students about beginning of life issues, the first place I go is women's health, because that's what they understand. That's their wheelhouse. And so I will go ahead, speak of the fertility cycle, give them an understanding as to, when you're looking at symptothermal, right? You're not just looking at cervical mucus, you're also looking at temperature risings. And so when I go through the whole thing, and I share with them that 1 month their temperature may not rise. Okay, maybe you did something wrong. Maybe you weren't feeling well. Doesn't go up the 2nd month, then you may ought to start paying attention more. Doesn't go up to the 3rd month, but your cervical mucus is fine. You get yourself to the doctor because you're uterine cancer patient waiting to happen. They get that, and they understand it. Now, whether they use it for themselves, that's another story. But the point of the matter is they get it. So my thought for you would be, go through the science. And I'm sure that when you look at any of the issues that they would object to, that we hold dear to us, there's science behind why we're saying what we say. Give them a good dose of science, and then they will not turn you off. They may not feel the way you do after it's all over, but they will be hard pressed to turn you off.
And probably I would say too, that resource you gave us once again is probably a good resource for her too, right?
What resource is that?
The NBD or the NCB Center.
Yeah, that could help you. That could really help you. The Charlotte Lozier Institute is also very, very good. They have a lot of good science behind the stuff that they use.
So much. I really appreciate it.
Can you spell that?
L-O-S-I-E-R, Lozier Institute. Now, there's another organization. I forget the organization, but I'm friends with the doctor that that runs it. It's called, her name is Dr. Angela Lafrangi. She's a, Angela is a obgyn, and she's done a lot of work on abortion and its effects on the cancer, on breast cancer. And she's done some work also on the effects of, yeah, on all the issues that could affect, you know, women's health, you know, sexual health, if that's what you want to call it, with breast cancer in particular. So she's a wealth of information. I would recommend, she's up in Somerset, New Jersey. I would recommend that you Google her name, Angela Lafrangi. Actually, you can call the National Catholic, you could also call the Catholic Medical Association, because she's a member of that and she's been for a while. And when you call, you could speak to Mario Dickerson. Mario and I have been friends for a long time. Just tell them I suggested that she call you to get Angela's phone number, to call her, and feel free to use my name. There are other, I mean, you know, and I can tell you, you're in a great place because Kathleen, Dr. Raviel, is a wealth of knowledge in all these things and can help you craft your language in a scientific manner. Because that's what's going to work. Theology is not going to work, unfortunately, but science will. So that's my recommendation.
That's a great recommendation, because bringing two parents through the process, they both had horrible deaths. And if we can get more people interested in what you call bioethics in a spiritual sense, it would make death, especially in hospital settings, a lot more humane and handled a lot better. Because those people don't have relationships with us. We only meet them in the emergencies or in the last minutes. So I think any type of training that could be done would be fabulous, because it was pretty horrible.
Well, I tell you, I don't want to be shamelessly promoting things, but I think it'd be well worth your while if you would consider, you know, taking that bioethics course, because it really will help you. You know.
Yeah, I just said really, that. I agree with you. I think that's an interesting course.
Well, work through Terry, and if you can get at least 5 people to take it, I'll make sure that we get a course open for you.
I'll send the information. I'll gather the information tomorrow and send it out through an email and see if anyone's interested.
Okay.
Terry and Professor, I'm sorry to interrupt. I just wanted to ask this quickly regarding the deacon giving me some misinformation. My concern is I'm probably not the only one that's been in this position or will be in this position. So do you know if perhaps this is addressed in the diaconate program? So we're all given this correct information?
It really depends on what program you're using. Every diocese does their own thing, you know, and I can't speak to what their training is, because I just don't know. But they should really, even in their continuing education, should be, you know, doing things or taking courses or seminars or what have you that could help them, you know, understand what the reality is in bioethics these days. And again, I mean, the CDU has a whole, you know, set for, you know, for this bioethics and the deacons. It's already there for them. You know, so, you know, it's really up to you. If you want to populate those courses, all you have to do is, you know, work through Terry. Terry will get through me, and we're going to populate it. That's the only way we're going to do this.
Thank you very much.
Welcome.
I'm very interested in it. That's true. Okay, so we'll end for tonight. Why don't we just say a glory be, and thank you for Professor Boza for this class, and we'll give glory to God, and then we'll end the session. In the name of the Father, Son, Holy Spirit, amen. Glory be to the Father, and to the Son, and to the
Holy Spirit, as it was in the beginning, is
now,
now, never shall be.
world.
World
Amen. Father, Son, Holy Spirit.
Well, God bless all of you. This was wonderful, very humbling. Thank you for having me.
Thank you.
Thank you so much.
God bless you all.
Thank you. God bless you too.
Thank you.